Is there a role for an add-on subcutaneous medication in uncontrolled hypertension? What's new in the recent guidelines for platelet transfusions? What are the latest clinical approaches to uveitis? We'll cover this and much more on this episode of the JAMA Editor's Summary. Hello, and welcome to our listeners around the world. Today is Friday, May 30th, 2025. I'm Dr. Linda Brubaker, JAMA Deputy Editor, sitting in for Dr. Kirsten Bibbins-Domingo, the Editor-in-Chief for JAMA and the JAMA Network. For this episode, I'm joined by JAMA Deputy Editor Dr. Preeti Malani. Hi, Preeti. Let's get started.
Hi, Linda. Let's start with an interesting trial by Dr. Desai and colleagues. This is the KARDIA-2 trial. The investigators studied Zilebesiran, an investigational long-acting subcutaneous therapy being studied for hypertension. Participants with uncontrolled hypertension despite first-line medication were randomly assigned to receive either a single dose of Zilebesiran or placebo, along with their standard antihypertensive medication. The primary endpoint was the difference in the change from baseline to 3 months in 24-hour mean ambulatory systolic blood pressure. The authors reported a significant reduction of the 24-hour mean ambulatory systolic blood pressure at 3 months in the Zilebesiran group compared with placebo.
JAMA Internal Medicine Deputy Editor Dr. Katz authored a Viewpoint that considers how Medicaid cuts affect the larger medical care ecosystem and emphasizes that patients, physicians, and employers could experience serious repercussions. In a separate JAMA Viewpoint, geriatricians Dr. Zetlow and colleagues discuss important considerations when caring for older adults, especially those who prefer to remain in their homes as they age.
There's also a Viewpoint by Professor Gostin and colleagues. It talks about a new comprehensive framework for action on pandemics from the World Health Organization. Gabriela Abulafia and colleagues provide a helpful overview of U.S. health policy focusing on Medicaid and the Affordable Care Act, or ACA. Their perspective article covers the ACA from initial implementation in 2010 all the way up to proposed regulation in 2025.
Yes, those viewpoints are important and very timely. Moving from broad issues to focus on a clinical issue, Dr. Magsudlu and colleagues contributed a JAMA review on uveitis. Readers will find this a helpful update of best practice approaches for both non-infectious uveitis and uveitis caused by systemic infection. And test your clinical skills with the JAMA Clinical Challenge that focuses on a patient with headache, fatigue, and aphasia. Just a hint, it ties into last week's JAMA Clinical Review.
This week's patient page is on risk factors, symptoms, and staging of testicular germ cell tumors, the most common type of testicular cancer.
To wrap up the clinical content this week, JAMA published a special communication from the 2025 Association for the Advancements of Blood and Biotherapies and the International Collaboration for Transfusion Medicine guidelines. Dr. Metcalf and colleagues synthesized these new guidelines and explain how evidence supports implementation of restrictive platelet transfusion strategies. Dr. Metcalf spoke with JAMA Executive Editor Dr. Gregory Kerfman for this week's JAMA Clinical Reviews podcast.
What do you consider the principal messages of your new clinical practice guideline for our listeners?
So the principal message for us is that really the recommendation is overarchingly to implement restrictive platelet transfusion strategies across at least the populations that were included in the guideline. And we made 11 overall recommendations, 4 strong and 7 conditional. And the reason we made what we called restrictive recommendations was that we didn't see clear evidence of benefit with liberal strategies for the most important outcomes of mortality and bleeding. And for that reason, we turned our attention to less important outcomes that were still important, but not as important as our main outcomes, but that were unequivocally beneficial for restrictive strategies. So avoiding acute adverse events, maintaining adequate platelet supply for those most likely to benefit, and lastly, probably least importantly, based on our rankings, healthcare-related costs. So I think that's the overarching message. And with the publication of guidelines, implementation is another important project. So that's something that we're going to turn our attention to. But that's the gist of what we recommended. And then I also want to just mention to listeners that we included a good practice statement that essentially says, look at the patient overall clinical context. We chose what we thought were practical thresholds for implementation. For example, if it's a platelet count threshold, we felt it was practical. But of course, there can be important variation in clinical context. And so we tried to describe that a bit in our good practice statement to help clinicians make optimal decisions in line with patients' values and preferences.
And we have a new episode from our JAMA Plus AI Conversations podcast. Associate Editor Dr. Yulin Schwen interviews Dr. Kandon and Chekrud about digital mental health solutions for employees.
AI is here to stay, and it's really exciting to see how it can be helpful with things like administrative burden, improving and optimizing the match between patient and treatment. But ultimately, a chatbot can't lose their license for providing low-quality care. So one thing we need to be very careful about is ensuring proper guardrails. Right now, if you go to ChatGPT and you display suicidal behaviors or ideation, they'll tell you that they're not a therapist and they'll send you to 988, and there's very little follow-up. So having kind of a robust infrastructure, and companies like Wobot are doing this well, to ensure that someone is getting the care that they need is really important. There was an article in the New York Times last week that focused on the American Psychological Association's take on AI. And one thing they pointed out, for example, is that AI tends to reinforce a user's beliefs as opposed to challenging a user's belief. Challenging a user's belief may be clinically appropriate for folks who are currently in crisis. So as excited as I am about AI, I think a word of caution is also warranted.
We invite you to read the latest JAMA medical news at jamamedicalnews.com or click the link in the show notes to find the latest articles in clinical medicine, biomedical research, public health, and health policy written and researched by our outstanding JAMA medical news team.
Thank you for tuning in to hear what's new this week at JAMA. These highlights were brought to you by Dr. Preeti Malani and me, Dr. Linda Brubaker. This episode was produced by Daniel Morrow, Shelley Steffens, and Dr. Krista Roberts at the JAMA Network. A link to this JAMA content can be found in the episode show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com, and thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.